thank you to everyone for coming. It's wonderful to see so many people here for today's seminar. Just a little bit of introduction. I'm Anne Grand, and I'm from the Wellcome Centre for Cultures and Environments of Health, which, for those of you who don't know us, is a fairly new research centre. We live in the Queen's Building, just up the hill, and our focus is on how we build and sustain the cultures that surround health throughout the life course. So we're interested in all kinds of things. I look after engaged research at the centre, so I'm interested in how we engage and collaborate with communities as co-partners in our research, for example, but we have a wide-ranging research portfolio. And so one of the things we very much want to do is to think about drawing all kinds of perspectives that address different issues around health, hence why today's seminar. I'm not going to be saying very much other than to let you know that we're welcoming people online as participants, which is lovely. And can I ask online people, if you haven't done so already, please can you mute your microphone at your end so that you don't, we don't get interference with the microphones in the room. I should also say one other item of housekeeping is that we are recording this seminar. So if you do not wish any contribution or comment or question that you might have to be on the final recording, please let me or my colleague Mel know, and we will edit you out of the final recording. Other than that, I'd just like to welcome my colleagues Angela Meadows and Lucy Aphramor, who are going to be leading today's seminar. I'll hand over to them and they will take it from here.
Thanks, Anne. Hi, thank you so much everybody for coming. We weren't sure how popular this would be. I'm not going to say a great deal about myself because those of you that know me will know that I can talk for hours and hours about myself and what brought me here and how I got here. But what I would like to do before we start, there should be some post-it notes on most of the tables or nearby tables. You're all very busy. I'd be interested to know what brought you here. Could you just jot down what is it that brought you here? What would you like to know, or why did you come? And just take a moment to do that.
Because there was tea is an acceptable answer.
Someone said there were biscuits. Or you can just chat to the people on your table for a minute. Okay, we're just going to sit on those for now. What we're going to do is, because there's so many people here, rather than have questions as we go along, if you come up with questions during the talk, and we'll give you a bit of time after each one as well, we'll ask you to jot them down, and then at the end we'll try and address as many of them as we can. So Lucy and I will each speak for theoretically between 20 and 25 minutes. And then we'll give you a couple of minutes to regroup, go and get more tea, go to the loos, what have you, and then we'll switch over. And then we'll sort of all come together and try and answer any outstanding questions. I'm sure there'll be a lot of things that come up. So one thing I would like to say is that because of the nature of the engaged research process at the Wellcome Centre, we're trying to attract a lot of very different audiences in this room. Some of you I know, many of you I don't. But theoretically, there should be scholars here from different departments in the university. There will hopefully be some health professionals or trainee health professionals, members of the public, various people that might have been interested for different reasons. And excuse me, and speaking to such a mixed crowd brings its own challenges. So we both have slides. We've approached it slightly differently. Mine have a lot of references on them. They're there for the people that want them. As simple as that. I'm going to whiz through most of the slides. I'm going to give you a broad overview. I'm going to be telling you the things that matter, but all the detailed stuff's there. If anybody wants it, that's what I put it down for. The other thing I'd like to tell you up front is a little bit about the terminology that I use. So both Lucy and I belong to a movement, a social movement, that is trying to change the way we look at fat. And as such, we are saying there is nothing inherently dreadful about fatness. We've been taught to sort of fear the word, don't call somebody fat, it's rude, all these kinds of things. We're saying there's nothing wrong with being fat. I'm fat, I'm brunette, I'm 5'4", and I'm fat, I have blue eyes. It's just one of those things. I don't attach anything negative to it. So I use the word fat. Sometimes I do that when I'm speaking to medical professionals simply because it freaks them out. It's wonderful. If I'm writing for a paper, I'll use higher weight. If I'm talking about a study that's used BMI categories, so normal weight, I do this a lot, normal weight, overweight, and obese categories, I will use those categories to describe their findings. But my preferred term is fat. So please don't anybody get upset by that or read anything extra into it. Okay, right. So this is where we see if it all works. Nope. Brilliant. Okay. So that's me. There's also details on the first and last slide if you would like to cite parts of this talk as a collection of things. Okay, so a little bit of background for those of you that don't know anything about weight stigma. Basically, it is stigma and prejudice based on body size, body shape, weight. Theoretically, that could be any weight, it could be underweight or overweight, but generally in modern society, what we're talking about is a very systematic devaluation and negative attitudes to people that are fat, heavier. The vast majority of fat people will tell you that they have experienced some form of stigma, at least once, mostly hundreds and hundreds of times throughout their life. A lot of this is actually underreported because people don't really know what we mean when we say stigma. They think we mean that somebody threw something at them or didn't give them a job. It's not the big things, and I'm going to talk a little bit more about that. It's quite often it's the small things that permeate through everyday life. Women get stigmatized more than men for their weights. They get stigmatized at lower weights. More and more heavier men are being stigmatized, but they do have to be quite a bit bigger. And it happens in just about every single domain of daily life. Okay, and this is what I was talking about just now, microaggressions. Quick show of hands, does anybody know this term? A handful. It kind of speaks for itself. Aggression is aggression and micro is little. So when we think about discrimination, we tend to think about, as I said, the really big stuff. And quite often people's lived experiences aren't those big things. It's the little things that niggle at them every single day. All these messages that tell them that they're worth less, they don't belong, they don't matter. And there are different types of stigma. So there's stigma between people, some of which is overt, some of which is less overt. So, people staring at the fat lady on the bus and like that. She knows you're doing it. Your friend saying, oh, I feel fat today, or does these trousers make me look fat? These kinds of things, they are sending a message, a cultural message, that fat is devalued. This gentleman, for want of a better word, was on the University of New Mexico graduate enrollment admissions panel. He isn't anymore. After the outcry over this, he tried to explain that it was an experiment. We all believed him. And it's not just interpersonal, we get these messages from our environment as well. So as a fat person, or, I'm sort of medium fat, there are people that are much bigger than me. I would come into a room like this, and I would say, oh good, the chairs don't have arms, so I don't have to worry about squeezing in there, but they're on wheels, I wonder how stable they'll be. Little things like that throughout the day, going to the doctor and not having a blood pressure cuff in your size and being made to feel like you're an inconvenience. Not being able to get clothes in your size, watching your favourite TV show and hearing a that joke. I can't believe they actually gave me permission to use this. This is Macy's website. And I just love this as a really nice example of a teeny tiny microaggression. One of the things that comes up again and again and again. They sell clothes for both women and plus sizes. And petites as well, so petites also aren't women. And handbags. And as well as stigma from other people, you can internalize stigma. So it's self-stigmatized. It's the voice inside your head that tells you you're fat, you're ugly, you're disgusting, you're worthless, no one could possibly love you. And in many ways, that's a lot more insidious. Certainly being stigmatized by other people can lead to that, but what we often see from experimental work is that it's the self-stigma that really drives all the negative stuff that happens as a result of that, which include a wide range of physical and mental health problems, metabolic problems. The one at the bottom there is quite interesting. Stigma mediates the link between BMI and health, and what that means is that people who are fat, and obviously I'm speaking in general terms here, not on an individual level, but people who are fat, who are not stigmatized, tend not to have the same negative health outcomes as people who are stigmatized. It's the stigma, being fat exposes you to the stigma, whether external or internal, and it's that tends to be associated with the negative health outcomes. Also, lots of very unhelpful coping behaviors. I was just saying to somebody at lunch, I've got this picture of a cheeseburger. I have no problem with cheeseburgers. Cheeseburgers are great. It was just kind of a representation of a pattern of behavior that people might feel is unhelpful for them. And the thing that I wanted to get really clear with you, because we talk about how high weight are associated with a range of health conditions, hypertension, diabetes, heart disease, some cancers. This is true. I'm not saying that's not true. What I'm arguing is, why is that association there? What causes it? And what's the problem? And when it comes to stigma, what's really interesting is that throughout the stigma literature, not just weight stigma, but racism, homophobia, and what have you, exposure to a hostile environment is associated with increased risk of hypertension, heart disease, diabetes. Living in an environment that is hostile to you is chronically stressful. I think Lucy's briefly going to cover that if I don't take up all of her speaking time. And that has negative effects on your physical health. So that's not just about fat people making up excuses for why they have diabetes. We're living in an environment that's very, very hostile for us. Poor obstetric outcomes is one I'll speak a bit more about as well. So yes, just a reminder about that there. The bit at the bottom is, it's quite interesting that historically cultures and countries where weight was actually idealized, heavier people were seen as the ideal. We didn't really get these very strong relationships between weight and negative health. It's getting pretty hard to find those countries and cultures these days because we've pretty much exported all our fat around the world. But it raises the question of whether or not it's the weight itself that's causing or that's associated with these problems, or whether it's the environment. Okay, I'm going to just do one of these, and the rest if anybody wants them. So all of this data isn't just from cross-sectional studies, it's from longitudinal studies and quasi-experimental studies, which is where they've done a kind of experiment, but they've used real-world events. And they've looked at outcomes before and after the events. And this one was in 6 months pre and post the 9/11 bombings. And they looked at birth outcomes in women in California. And those of them with Arabic-sounding names had worse birth outcomes after than before. And there were no differences seen in women that didn't have Arabic-sounding names or in other states. So, and there's some more here from the LGBTQ literature, looking at the impact of banning or legalizing same-sex marriage and the impact that has on health and health outcomes. And they're all saying the same thing. So Lucy's also going to touch on this. The way that stigma impacts on outcomes, whether it be health or life outcomes, and they're all related. There's direct impacts through biology, and there's indirect effects through limitation of life choices and socioeconomic status, which is also linked with health. And very many people actually cross identity boundaries, so they may be fat and an ethnic minority and a woman, and all these things compound. They tend to go together. Okay, are there any health professionals in the room? Excellent. Any healthcare students? That's a shame. Okay. So I'm just going to whiz through these again. The reference at the bottom there, Poole and Hewitt, actually includes most of these. It's a very good resource, even though it's 10 years old now. Very, very strong evidence of both implicit, so the stuff that we don't necessarily vocalize, and explicit, the stuff we're happy to admit to researchers, anti-fat bias in a wide range of healthcare professionals. So nurses there would rather prefer not to touch obese patients. Seeing obese patients is a waste of doctors' time. I was going to mention this one. This is a study done in Nottingham a few years ago, and they had 1,100 healthcare students from across several different departments. And out of those 1,100, 16 of them managed a neutral or better overall attitude towards high weight people. And your dentist may not sympathise with you. And dietetic students, these read one of 4 identical descriptions of a patient, except in some of them the patient was described as fat, and they rated the fat ones health as being worse, their diet as being worse, being less adherent to treatment recommendations. And if there are any sport and fitness professionals in the room, I have just written a paper that was published yesterday where I review some of the literature. Thank you. Where I review some of the literature on this, and the reference is on the slide. And there are still some free downloads available, so if you can't get it, let me know. Okay. And as you might expect, this has a massive impact on the patient experience of healthcare. This cartoon, which I use a lot, kind of really sums it up. And there's just some truly awful quotes here. Let's just go back. Yes, you're perfectly healthy, but it's not going to last. You're going to be a diabetic before you're 30. If you lost some weight, your husband would find you attractive and the sex would be fine. I've been prescribed weight loss for a broken toe, strep throat, anemia, and a dislocated shoulder. And this was an interesting one. This is actually from one of Lucy's studies, I think. It's such a revelation to be treated with respect when it happens. It shouldn't have to feel that special. So the thing is, even though, of course, not every healthcare professional treats you badly, there will always be many, many more who are respectful and decent. But every single time you go into a healthcare encounter as a fat person, you're preparing mentally and emotionally. What if? You know, it's not a neutral experience for us. And there is that website, First Do No Harm, fathealth.wordpress.com. There's some quite interesting examples there if you'd like to see more. Unsurprisingly, fat people tend to avoid healthcare. They avoid preventive care because they don't need to go and see the doctor, which tends to mean they get diagnosed further along when they do need to see a doctor. They're more likely to use emergency rooms and what have you for conditions. And what else? And I've just got 3 examples. There's no doctors in the room, so I probably could whiz through these as well. Just reviews of cases to see how medics actually responded to the guidelines. So this was in a bariatric centre of excellence, which means they're supposed to be really good with fat people. They looked at the 3 most common antibiotics administered in that hospital. There were guidelines, and the adherence to the guidelines by the doctors for the top 3 were 8%, 3%, and 1.2%. Underdosing, of course, will be associated with more recurrence and resistance of bacteria, and of course, then we'll read papers about how fat people are prone to more infections and, you know, harder to treat. Another one for cancer, a lot of people are treated with chemotherapy for concerns that the drugs might, you know, linger in the fat tissue, but there's no evidence of this. And of course, you're not being treated correctly. One study that looked at this estimated that a correct dose could save up to 6,000 deaths per year from breast cancer alone. Fatal misdiagnoses, more common in fat people. A couple of case studies. This lady was in Germany. I think she was 60. She was gaining weight. She was having trouble breathing. Her doctor said, you know, it's just diabetes and lack of activity. Gave her some anti-obesity medication. She was getting worse and worse. And as an older woman, she didn't really question her doctor. But at the point where she could barely stand up, her daughter sent her for a second opinion, where in a 7-hour operation, they removed a 62-pound tumour from her. That was crushing her windpipe. She lost 40 kilos. She's doing very well. This lady was doing less well. She died in May this year. Her doctors just kept saying, well, you're fat, just lose weight. And she used her obituary to actually tell fat people to fight for their rights to be heard and not to just lose weight as an answer for everything. And one of the things we wrote about in our blurb for this seminar is the war on obesity, the so-called war on obesity, helping anyone? And the thing is, well, I mean, obviously the answer is no, really. But all this focus on fatness is really missing a lot of other stuff, and it's really unhelpful for thin people also. So, for example, just looking at metabolic health and BMI, which is something that most healthcare professionals will be aware of, just using BMI, normal weight, overweight, obese categories as a marker of metabolic health gets it wrong for about 75 million Americans. So thin people are being missed because everyone thinks, oh, thin people don't have these problems. This is just something that happens to fat people. So they're not getting treated properly, which could be one of the reasons that they have worse outcomes than fat people with metabolic problems. They have much higher mortality rates. Fat people tend to survive better even if they have these conditions. I included that particular reference, number 2, because despite their best efforts to cherry pick all of the data in their study and not mention the thing at all, it is still in there. So that's an interesting one. This is another study that I like. They looked at women who had been referred for polycystic ovarian syndrome to a specialist clinic. And they found that the BMI of these women was 34.5 on average, which would put them in the obese category. They also looked at women who were being identified as having polycystic ovarian syndrome through an employment screening, a pre-screening. They didn't know they had it. Their BMI was much lower, it was 27.6. The percentage of referred women who were obese by BMI standards was 64%. In the non-referred employment group, it was 28%. And the referred women were also more likely to be white, which basically means if you're rich and white and fat and have problems that might be symptomatic of polycystic ovarian syndrome, you're going to get referred to a clinic. And then you get all these papers coming out of the clinics that saying all our patients are fat and white and have polycystic ovarian syndrome, so fatness causes polycystic ovaries. So that's just an example of referral bias. And kids. So anti-fat attitudes have been demonstrated in children as young as 3, and that's not that unusual. It's the most common form of bullying in schools. They're learning it from kids' movies. If you actually start looking for it, this stuff's everywhere. They're learning it from school health promotion and the surveillance, so the measuring of kids' weight in school, that fat is bad. Eating disorders in ever younger children is also on the rise, including the most severe forms of hospitalizations in under 12s. Eating disorders have the highest mortality of any psychiatric disorder, and the fear of being fat, the fear of fatness, is an underlying theme throughout all these. It's quite hard to get an accurate estimation of prevalence, but through going through a bunch of different studies and a couple of reviews, approximately 3,200 cases of eating disorders per 100,000 person years. This is in adolescents and young people. Just for comparison, type 2 diabetes in adolescents is about 12.5 cases per 100,000. And fat kids get eating disorders too, but everyone says, oh, no, that's great, you'll lose weight. And they're not being treated properly for a very, very dangerous condition. So, what can we do? Lucy's going to talk about the broader stroke. She's going to talk about it more from a policy and a societal level. But I wanted to speak very much to the individuals in the room. As individuals, the thing that determines our health are almost entirely outside of our personal control. But we do have some agency, and there are some things we can do if we want to make decisions and choices to improve our health. If you want to jump out of aeroplanes and live a life of debauchery, that's fine too. But if you're the kind of person sitting there thinking, yes, but what can I do to be healthier? Here's some stuff that might be useful to you. So this is an interesting study that was, it was a data analysis of 170,000 people. And they knew what people weighed and they knew what they wanted to weigh, so their ideal and their actual weight. And they also knew how many sick days they'd had in the previous 30 days in the previous month. And what they found was the more unhappy people were with their weight, the more ill health they experienced, physical and mental ill health, even after controlling for BMI, which is just astonishing. So it's not just that they were heavier and more unhealthy, It was they were unhappy and more unhealthy. This one is just amazing. So this is from the Aerobic Centre longitudinal study. So if anyone's interested in epidemiology, this is a really good place to look. It's a big cohort. They've been gathering information about thousands and thousands of people since the 70s. And they have a lot of very good data. It's a very well-run study. And this was a longitudinal sort of follow-up from start to finish. And they were looking at which people got a new diagnosis of diabetes. And looking at the baseline, so when they first started, the things that predicted higher risk of developing diabetes were family history, 46% increase, age, 3% increase for every year, and weight dissatisfaction, being unhappy about your weight, 83% increase. But what's really astonishing, and that didn't work because that was supposed to be bit by bit by bit, was that compared to people who were satisfied at the start and at the end, who they called having a risk of 1, so no extra risk, being unhappy at time 1 and time 2 tripled your risk of developing diabetes. And all of these results held after controlling for BMI. Being satisfied with your weight and becoming unsatisfied increased your risk a little bit, not significantly. But the amazing thing was starting dissatisfied and learning to be okay with your weight brought your risk of developing diabetes back down again. And I tell people that and they go, yeah. I think, no, you haven't understood what I just said. This is just amazing stuff, and it's a really interesting area of research. It's quite new. Another one on fitness. So this was a study of 26,000 men. It was published in one of the best medical journals in the world, certainly one of the most respected, we can argue about the best, in 1999, so nearly 20 years ago. And they were looking, it's from the same cohort. They give them maximal treadmill tests, so they put them on a treadmill with a gas mask on and get them working really hard to see how much they can do. And again, they compared by BMI category, so it's the normal weight category, overweight and obese category. And compared with normal weight category people, participants who were fit, normal weight participants who didn't have a moderate level of fitness had over double the risk of all-cause mortality over the follow-up period. Overweight had a higher risk, and obese category people had the highest risk, about 3 times the risk, which is what you would expect. What you might not expect, going backwards, forwards and backwards, is that. So if you were fit, regardless of which BMI category you fell into, your risk was almost identical. And that has been replicated in all different kinds of populations, including those that had risk factors to start with. Fitness isn't usually included as a potential confounder, potential explanation of results when we read these studies. Stigma also isn't, because that's quite hard to control for. So when you're seeing these results about a relationship between fat people and ill health and what have you, we're not seeing the whole picture at all. We're not seeing what's explaining it. And if you don't like exercise, this is another study, and they looked at 4 healthy habits, one of which was exercise, which they defined as 30 minutes, 3 times a week, nothing major, alcohol in moderation, not smoking, and 5 or more fruits and vegetables a day. And what they found was, compared to a normal weight person who did all 4 of those healthy things, a normal weight person who didn't had twice the risk, an overweight person by BMI had nearly 4 times the risk, and an obese person who was a smoker, didn't exercise, didn't get their fruit and vegetables, and drank too much, had nearly 7 times the risk. But look what happens once you start introducing healthy habits. That's 2, that's 3, and that's 4. Another thing you can do is actually refuse to be devalued. Internalizing stigma is really, really bad for you. Refusing to be stigmatized and challenging stigma as a whole is much better for you. At any given moment, there are costs sometimes associated with standing up to the people around you and fighting the major drivers in society. There can be personal costs. You may not be in a position of power sufficient that you feel able to do those things. It comes with costs and benefits, but on the whole, people that challenge stigma tend to do better. People that internalize stigma completely across the board do worse. Not many people have looked at this in fat populations yet. There's some evidence from what we call the Fatosphere, which is the collection of blogs that write about fat acceptance. If anyone wants to know more about that, come and speak to me. Coming out as fat, saying, yes, I'm fat, get over it, is very empowering and it's quite good for your well-being. This is one area of work that I've been doing. I've been looking at stigma resistance, weight stigma resistance, and it's associated with less weight-related distress, better self-esteem, and so on. I'm not a parent, so I'm not speaking from a position of knowledge here. I have put together a list of useful resources from people that are parents and who are children, and that might be helpful for you. Because, you know, it's challenging when you're in an environment that's telling you you have to police your children's bodies all the time. And what everyone can do is what I call live, move, love, care. Live your life, stop focusing on the number on the scale. Take care of yourself, move a bit more if that's something that you enjoy. Do things that make you happy. Try not to do things that make you unhappy, and be nice to yourself and other people. And for those of you that don't know what this is a yay scale. And it was created by a woman, an activist, a very famous lady called Marilyn Wan. And I don't know if you can see, but the dial actually says things like fabulous, wonderful. So when you step on it, it says, you're amazing. And we actually have a yay scale with us that you can have a go on later. And you can buy these from Marilyn as well. I don't get any commission on these. I just think they're the most amazing things. It sounds like a cute idea, but wait until you actually step on it. It actually changes the energy in the room. It really is an amazing thing. So yeah, my final recommendation would be to yay yourself regularly. Bless you. If you want to get in touch with me, email, Twitter. I was actually on a podcast that was released last night, talking in a bit more detail about some of this stuff, and also about organising a conference where everybody in the room hates everybody else in the room. So you can, I didn't put the whole link on, it was huge, but if you go to Body Kindness Podcast, I'm the most recent one. And there is also a Weight Stigma conference, which I accidentally founded 6 or 7 years ago by not intending to, and is now in its 7th year. We've been all over the world, and next year we're in Canada. So the website is just stigmaconference.com, and you can go check that out if you'd like to know a little bit more about it. And I will hand you over to Lucy.
Yeah, you can give them a chance to think about it.
Oh yeah, you can have a chance to think about it. So we said a couple of minutes. Jot down or speak to the people on your table any thoughts that you might have, any questions you might like to ask after this. And then we'll sort of again gather them together at the end. So we'll give you a few minutes to just do that and replenish and everything else, and then.
Are you ready to go?
Yeah.
Ready when you are then. So if you'll need to be over this side. That's okay. Coming through. Coming to you now. Right, I will go to full screen.
Sorry. Oh.
And then, there you go.
Great. So are you looking at that for your guide? Okay. Whichever you prefer. Yeah. I just don't want to block the view of you, but I think we're fine.
Okay, everyone. Hate to break up a good chat, but I always end up doing it. We are ready for part 2, so I will hand you over to Lucy.
Okay, great, thank you. Well, thank you very much, first of all, for inviting me here. And when Angie asked us to think about why we've come, I've come because of Angie. So thank you for that. And it's sort of chance conversations that we reckon 2012 we met, wasn't it? Yeah, so thank you very much. And Angie asked me if I'd talk about health and fatness and what gets missed out in the equation, in the sort of mainstream narratives. So a bit about my background. I'm a dietitian and a poet, and it's becoming increasingly difficult for me to separate them. And I was working with somebody on poetry recently, and he said, "Oh, you're a poetician." And I think that, which I thought was great. I previously worked in the NHS for about 10 years. I started working in the community in Coventry, and then I specialised in cardiac rehab. And then I left and I ran a social enterprise. And this is some of the stuff that I've done. That was 10 years ago, the Body Project, which was, I was really interested in looking at how do we change narratives of body shame into narratives of body respect. I've written, I'm not an academic, I would think a civic intellectual, but I've written a lot of papers that have been very well cited. This is 2 two of them there. And I've also written open college network courses around body diversity. So I'm interested in shifting conversations, including in academia and medicine, but not limited to that. And Body Respect, the book that I co-authored with Linda Bacon, and there's some really useful ideas and concepts in there that we spell out. But I think I would take myself to task on some of the things on there. So that's, you have to read it and see what you think. And then this is a screenshot of me performing, and maybe there'll be a bit of poetry in today. So that's just a bit about my background, really. And I think very often when we look at health narratives, these are the things that our attention is drawn to. So we're asked to think about diet and lifestyle, and that gets conflated into weight. We end up speaking about thinness and fatness. Increasingly, mental well-being gets in there, and I think resilience and recovery are terms that are often used. And what I've noticed more now is that the social determinants of health will also get a mention, particularly stigma, which is great to see that being mentioned, trauma, and ACEs, which stands for Adverse Childhood Events. And what I'm interested in is how do we make sense of all this? What's the moral response to this? And this is where we're starting. A Healthier Future, that's a Scottish document. There's two. There's one looking at diabetes, there's one looking at weight. This is the English Public Health England below, looking at diabetes. This is the top one, and the food fact is from the British Dietetic Association. And you can see I've just started blanking out oppressive words around fat, partly to draw attention to the fact that if we pay attention to language, first of all, we're paying attention, and in itself that can send us in different directions. And I just want to stop using words that I think oppress. And when we use words that give the idea that BMI is a useful measure of health, we miss the fact that society matters. When we miss the fact that society matters, we end up missing the fact that racism impacts health, that weight stigma impacts health. So Angie was saying that I was going to speak about some of the things we can do. And some of the things we can do are in everyday conversation, really apparently small things, that even just helping us to stop and think, what are we actually saying, can really make a difference. So, health of the nation. This is what we're told. If only everybody in England would eat less and move more, everybody would become thin, and we would get rid of health inequalities. And the NHS would just be sloshing in money. That's very much, when we think about it, that's very much the narrative that we're given. And of course that rests, so sort of tangled into this is the idea that not just that everybody can and should be thin, but that everybody can and should want to be thin. And the idea that, and I think really crucial to this is the idea that if you eat less, you will lose weight and be healthier. And this comes from evidence-based practice. A lot of you will be familiar with the term evidence-based practice. And if evidence-based practice, if this is the definition of evidence-based practice, we're going to get the best quality evidence we can, and we're going to use that to base our decisions on. It would mean that if we're looking at weight or intentional weight loss, we need to get randomised controlled trials. More than one, we want a systematic review. And we want them not just for 3 weeks, not with only 4 people in, we want the largest studies possible for the longest period of time. So I want to imagine, if we think of the evidence, so this group over here, you're going to be the lose a few pounds group. You're just going to lose a few pounds, that's it. You're going to meet up once a week, and nothing silly, just healthy, sensible eating, bit of exercise. No Atkins, no Zone, no rhythm method, no laxatives, no sweatsuits, no taking up smoking, no dropping any speed, just healthy, sensible eating. And this group over here, we're going to be the feel-good group. So we'll do, any ideas of what we're going to do?
Dancing.
Dancing, excellent. Singing, dancing, baking, socialising. Extreme knitting, laughter yoga, bingo. Yeah, we're just going to meet up and have fun.
Lots of sex.
Lots of sex, well. So we're going evidence-based medicine. Randomised controlled trial, systematic view of randomised controlled trials of intentional weight loss with results at 2 years. What's happened to our weight over here? Yeah, I do. Yeah, so how are we feeling?
Yes.
Great, maybe a bit tired, who knows? But great. Educated. And what's happened to our weight? Probably about the same. If we look, about the same. Over here, if we look at the evidence, how are you feeling over here? Bit crap. Bit crap, yeah?
Sick.
And what's happened to your weight?
It's fluctuating.
It's fluctuated. So what? Does it matter?
No, it's damaged my heart.
Damage your heart. Yeah. And the chances are, if we look, so this is a really, really key thing, because this is what Public Health England, British Dietetic Association, NICE guidelines hinges on. This idea, everybody can and should want to be thin, and it follows from that, implied in that, is that we have a safe, scientifically proven method for getting a thin person, for getting a fat person into a thin person. And that a person who is fat and is now thin has the same metabolic profile as somebody who's always been lean. So these are all the hidden assumptions. So if we look at this, this is the study, this is intentional weight loss with results at 2 years. Shows that the benefits of dieting are simply too small and the potential harms are too large for it to be recommended as a safe and effective treatment. That is it. But don't worry, if you want to write some weight management guidelines, just ignore it. Quite simple. All you need to do, as in the NICE guidelines, is choose a scope that doesn't include this. For example, make your title the benefits of lifestyle change for weight loss. Yeah? But you can see the implicit bias in that. The benefits of, put any drug in there for something. Yeah, the benefits of conversion therapy. The benefits of thalidomide. It would be unthinkable for us to use the standards that we apply to fat people's health to any other form of intervention in medicine. Or maybe it wouldn't be unthinkable, it should be unthinkable. But what I'm saying is it passes unnoticed, both in terms of ethics, human rights, and quality of science. And you're absolutely right. So this is a quote. So the British Nutrition Foundation have a very similar quote, but I've taken this from the SIGN guidelines. SIGN guidelines is a weight management protocol. States that weight cycling is a common condition and it is a risk factor for all-cause mortality. And the British Nutrition Foundation go on to say for cardiac mortality in particular. And there's further evidence from the 7 Nation studies, the Women's Health Initiative and the Iowa Health Study. So trying to lose a few pounds is not benign, both in terms of metabolic health for individuals and also for the way that it gives this idea that everybody can and should be thin, which leads to fat shaming and misses the fact that our health is primarily determined by power relations in society. I'm going to say a bit more about that. Before I get on to that, universal currency. You are worthy of love and respect. This is the starting place. Whether you intend to start a diet after you've heard me speak, whether you spend your whole life dieting, if you have until now been supporting somebody in a diet, if your whole career has been around getting people thin, we need to know that health resides in justice, and justice resides in us knowing that everybody has innate human dignity, even when we make mistakes, even when we're ignorant and arrogant. Because I think it can be really hard for us to move on to a place where we can have real dialogue and meaningful conversation if we are dehumanising somebody for any reason. So I've just put, well, shouldn't be just there, but I've put this in, that this is grounded, our work for transformation has to be grounded in respect. It doesn't make us not accountable, it doesn't exonerate us from harm that we've caused, but the harm that we've caused does not dehumanise us. So flipping it round, some of the questions that I found really helpful. When should I use an approach that disregards gold standard randomised control data? The answer is never. Even when everybody else is using it. Even when your professional organisation tells you should be doing it. Even when it's hard. And this is from the British Dietetic Association's TeenWise website. Funded by, this particular project is funded by the Department of Health and it's experts within the organisation. And it is absolutely brutal. So this is the damage that is done by a dieting narrative. Something like this passes without comment, as if this is a useful thing to do. So here we have, ostensibly, we have our fictional youth who says that she feels gross, and the response is, eat less, move more. And it's the same with the boy who writes in wanting help with binging. It's the same with the child who writes in saying he's been bullied for his weight. And that is the damage of it. The damage happens at the level of the person, and because it creates a society where this sort of oppression passes without comment. And this is on a health side. This is where people are turning for support. So it just increases the corrosive nature of shame, and exactly what Andy has been talking about. When should I use an approach that shames and depresses, like weight correction? Just never. Because of that. Because when we do, we get people saying that they're gross and nobody says anything about it. What about health then? Where does lifestyle fit in? So this is a picture that's at Carding Valley in Shropshire, where I've come from this morning. And so if I put myself into an equation called Q-risk, which looks at risk of heart disease, in a crowd of 100 people with my parameters, one of them is likely to have heart problems in the next 10 years. What do you think happens if I double my weight? Any idea?
Like 2 people in a 100.
Right, so we think it's going to go up. Yeah, and that's certainly, if I ask you, if you read the British Heart Foundation, if you read British Nutrition Foundation, if you read British Dietetic Association or the Public Health England, there's absolutely the message we get, isn't it? If my weight doubled, my risk of having heart problems is going to go through the roof. In fact, it doesn't change. And if I slim myself back down and I change my postcode to where I used to work in inner city Coventry, then my risk doubles. So one of the fallout of the anti-fat agenda is it conflates, it makes lifestyle equal health. It has this idea, if you just look after yourself, you'll be healthy. And it gives the picture of health as thin, white and middle class. There's nowhere in current health narratives for a fat person to see themselves as represented as healthy. And that is problematic for lots of reasons, including, where was I going with that? Anyone? Including what? Where was I going with that? Don't know.
Next slide.
Sorry? Next slide, I'm just thinking was clearly, yeah.
You said went off on a tangent.
I did go off on a tangent.
Yeah,
but if you never see yourself represented, it's that. So I think, well, it disappears stigma, it disappears racism, it disappears trauma. So I'm not talking about fatness in there, but I'm saying when this is the picture of health, I get read as healthy, and therefore moral. That's where I was going with it. It's a problem, not because, if my moral worth was not tied up to being healthy, it wouldn't be so much of a problem. But it's particularly a problem because you're never represented as being worthy of respect, and that is the problem. Thank you for bearing with me. So the thing with BMI-based healthcare, there is no such thing as society in BMI. It's a brilliant Thatcherite meme. It's fantastic. And it passes unquestioned. There's no such thing as trauma. There's no such thing as austerity, stereotype. Daniel Blake, He couldn't afford custard creams. And so all this sort of stuff, so this is biochemistry of discrimination. There's a biochemistry of discrimination that we can link to the things that we get told are diseases of affluence or non-communicable diseases, that if we looked at it through a different political lens, we can call them power-related illnesses, hypertension, type 2 diabetes, stroke. There's also trauma. So we know, so the current agenda around health is we're going to tell people what to do, they're going to do it, and they're going to be healthy. And that completely misses the fact that trauma impacts people's physiology completely independent of lifestyle. And also, things like the stages of change, in some of the models that we're given to think within, and the stages of change is the stages of same old, because it ends up locating health in health behaviours. The theory of reasoned action is the theory of reasoned injustice, because we keep on narrowing health down to lifestyle. And another difficulty is that the social determinants of health are often misconstrued as the socially distributed ability to eat well and keep active. So by that I mean, poverty is understood as poverty affects health because people aren't able to eat well and be active. And if we go into Exeter and everybody, so even here, if we all eat the same diet and we all have the same activity, and some of us go back to an abusive relationship, then there will be differences in health that cannot be explained by diet and exercise. And equally, we're all eating the same, but let's say there's 10 people in the group who make the decisions about what we're going to eat. Will we all have the same health outcomes? Or what we're given is insect burgers and really bitter vegetables, which nutritionally is complete, but will that influence our health? So the way that we've been, certainly the way I was trained to think, was to reduce nutrition to nutrients. But of course, food and eating serve a range of roles and meet a range of needs. And that these are often that the role of power in the eating and feeding relationship, the ability to feed ourselves and our families with dignity, is missed out of lifestyle change. So we get things like this. Much of the world's disease burden results from a few largely preventable risk factors, most of which are related to diet and lifestyle. It's just not true. This is magic realism. Mortality and morbidity is greatest in those who are least advantaged. Much of this is attributable to colonisation, militarism and neoliberalism, not to diet and lifestyle. Lifestyle behaviour change models that are an innate part of the whole anti-fat agenda do not and cannot accommodate trauma. So they reinforce and hide trauma and inequity. They prevent more appropriate interventions from being developed and researched. They block understanding and transformation, so people who mean well are not helped to think things through critically and develop things that will be much more useful. And so we carry on doing things, not realising that they're causing harm. They ignore vast amounts of data. This is nothing new. It's all out there. But the models that we've got sideline it. They enable the continuation of toxic power, and they privilege, shame and oppress. This here, so the word I've blocked out is around fatness, but this is from Public Health England, we could put the word trauma in there. And if we change sleep apnea for disturbed sleep, then it pretty much holds true. We need to talk about trauma. We need models that help us make sense of the intergenerational transmission of trauma. Models that lead to a decolonised healthcare. When should I use? Yeah, so same here. And if we look at, so type 2 diabetes, look, this is a big Canadian study, and it shows that even when you control for sedentary behaviour and weight, that type 2 diabetes is primarily a disease of material and social deprivation associated with poverty and marginalisation. If you want health, then we need to tackle austerity. It's not going into food banks and getting sugar-free, low sugar biscuits there. That is not the answer. It's changing society so we don't need the food banks in the first place. So, when we explain health outcomes as primarily a result of lifestyle behaviours or weight, we're cow-splaining, which is inherently racist and sexist, because its deep assumptions are that experiences of gendered and racialised injustice do not count as relevant in the health conversation, and they do. They are profoundly and fundamentally relevant to the health conversation. When should I use an approach that ignores all this? So what can we do? We can reimagine health. We can reimagine health to build a society that is grounded in respect, where when we wake up, so that people wake up into a world knowing that they are respected. That the anti-fat agenda is inherently neoliberal, that preventing fat, eradicating fat people causes harm, and it reinforces a supremacist mindset around perfection and the binary thinking, good, bad, black, white, gay, straight, that puts us into these categories, which in itself wouldn't necessarily be a problem, except that they're always ranked, one is better than the other. So we have this opposition, we're always in competition with each other. My sense of being okay can only come within that framework at somebody else's, of me seeing somebody else is inferior to me. That is not the way forward for health or justice. Or we can switch it round and look at security. If we want health, the UN definition of security, where the freedom to live in dignity, free of poverty and despair. For me, that's the way. So the way that I theorise it, I call my work Well Now, my philosophy. And it's where no one is starved of food, connection or dignity. That's where health resides. I've just got a bit on here. So if I put health justice in the middle, this is the theory that I use to prop it up and to think things through, to support dialogue and conversation and moving forward. And it starts with that your story matters, your experiences matter, your emotions matter. And look through the lens of compassion, curiosity and connection. I won't say too much about that, I've got stuff on my website. And on a really sort of simple, everyday level, we can see, if I'm working with somebody, let's say that they've come to me and they've been told that somebody's told me you need to lose weight because of your diabetes. We know that if we go along this chart, that dietary quality and our relationship with food can impact blood glucose control independent of weight change, including in fat people. We know that activity can improve diabetic control and mental well-being independent of weight change. We know that body awareness can, and that respect and fairness will also influence somebody's health in relation to diabetes and everything else. So we can focus on health gain in its widest sense, which includes self-care and bridges it with social justice. To say that compassionate self-care is important is not the same as saying social justice doesn't matter and vice versa. And of course they're interlinked. The nature and nurture is always a nexus, it's always interlinked. And so, where's the... No, I've lost. So I was giving the last word to Virginia Woolf, who said something about that we need new words and new ways of thinking if we're going to do things differently. So on which note, a bit of so one of the ways I've tried to do that differently is also putting emotion into work. So right in this room, 1 million women hours have dragged past in our thoughts of being more by being leaner, cleaner, slimmer, trimmer, thinner. Shame. I was taught your contours. I was not born calling any flesh excess. Whoever you are, however much you wish your body different, I count you in when I ask which of us has value. Through all the stages of the cells you would create, your worth holds fast. Your worth is stable, unchanging, innate. Thank you. So Angie and I thought we'd give you some more time to have a chat and think things through.
Okay. I'm going to interrupt you again, I'm afraid. I'm going to hand over to Angela and Lucy again in a minute for open questions. But one thing I did want to say is that if you would like to hear more about the seminars that the Centre runs, please go to our website, which is exeter.ac.uk/departments/CCEH, and you will land here. And if you click on the contact tab, that will enable you to sign up for our newsletter, where you will get information about seminars and things coming up. So come and find us. Angela, over to you.
Thank you. Okay, we'd like to give you about 10 minutes or so, 10-12 minutes, where we will try and answer anything you throw us, as we like to call this segment. But what about their needs, which is usually the first question we get, first question I get. So anyone that has anything that they'd like to share, anyone who has a question that they don't want to share to the room, feel free to get in touch with either me or Lucy afterwards. That's perfectly fine. But yeah, take questions. Yes?
With the stigma from healthcare professionals, is that at all influenced by the person's own life?
Not as much as you would think. So there is some evidence of slightly lower stigma amongst heavier medics. There's not been a lot done in other healthcare professionals, but certainly amongst doctors and some medical students. But still not a lot. There's a lot of, even though they're slightly better, they're not great. There's, very embedded anti-fat attitudes and a lot of self-disgust as well. They also don't know why they can't lose the weight. It's because no one's providing an alternative explanation, but it's very, very deeply embedded. Yes.
Have you got any idea, seeing that previous question, is that linked to gender of health practitioners? Got any take on that?
Yeah.
I need to repeat the question.
I was about to, yeah. For those of you that couldn't hear, it was a question about whether or not the relationship between health professionals and stigma is gendered at all. As with most of the weight stigma literature, there tends to be, there's not huge differences, really. There are some differences. Men tend to be slightly more stigmatizing than women. I'm not sure that if anybody's looked at that by the women's weight and the men's weight, because I think, those of us that have lived the last 30, 40 years trying to diet and failing, are possibly a bit more tolerant and compassionate and understanding that it's not as obvious as it looks to an outsider. But so, yeah, usually men come out slightly worse in terms of having higher anti-fat attitudes, but there's not a huge difference. Yes?
I get this sense that things are changing, like on a global basis. We have the film Embrace from Australia, and like on what I see on social media, it's like huge changes. People really picking up on people like Body Positive Panda and putting out messages which are really questioning the diet industry, and all of the industry is making massive amounts of money out of making us feel shit. I want to how can we kind of collaborate better so that all of the streams, so academia and the popular bloggers and the filmmakers, just to really kind of build this movement. Other than having
yeah, I know what you mean. It does sometimes seem like there's a bit of groundswell. I mean, more and more often these days I'm hearing about someone who said something appalling on Twitter or on TV and what have you. And the reason I'm hearing about it is because there's been an outcry. So on the plus side, yes, people are fighting back. However, it's still happening, for a start.
I feel like it wasn't like, oh, it's okay now. That wasn't the question. It's just like,
how can we do more?
This is like seeds of change. Like, how can we really, really build it so that the message goes? It looks like it's often the message is coming from the bottom up.
Yeah, I think unfortunately, so this, I'm doing this for quite a while, not as long as Lucy has even, and I've become a bit cynical, but unfortunately I think a lot of those seeds are not going to grow into beautiful plants. I think they're coming from poisoned ground. I think, you know, like I went to one of the screenings of Embrace, and I don't think there was anything particularly problematic in the film. It was great. But Taryn, who did it, you know, she was taking questions from the room, and everyone's agreeing with her. Yes, that's okay, so long as you're healthy. You know, the messages aren't really coming out. You're talking about the billions being made on making us unhappy and hate ourselves. There's a new wave of commercialism where billions are being made by telling us to love ourselves, but only if we use this product or look a certain way. I mean, people like Body Posy Panda. She's a petite, I don't know, she's white, her skin's a little bit darker, but you know, a fairly small, nicely shaped. Yes, she's got a tummy, and what have you. But there's still an acceptable face of body positivity. You know, yes, it's okay for these women that are sort of middle class and white and have a little bit of a tummy and they wear a size 14 to feel okay about themselves. You know, but if you're really fat,
She really magnifies the voices of the marginalised, though. I think she's
yes.
really.
I mean, I love her. I think she's great. I'm just saying there's still an acceptable face of body positivity. Yes, you're right. We need to harness this sort of inkling of a groundswell. And 5 years ago, I was saying pretty much the same as you. You can see it changing, and now I'm bitter and twisted and broken. I don't know.
Yeah, well, can I pick up on that?
Yes.
So I think, so absolutely what Angie's saying, and I think one way that we can, so how do we avoid falling into the trap where we're just packaging mindfulness or, you know, this whole sort of commodification of things? And from one of the sort of, I don't know, exercises or just a way of being in the world is this idea of impassioned praxis. So praxis means that we're trying to always link theory and practice. So we're asking, why am I doing that? Why am I using that particular word and not this one? And I can't remember who it is. I can find the quote, but the quote is that it guards against actionless thought and thoughtless action. Because I think there's some things like questioning evidence-based practice. I mean, that's heretical. It's completely heretical. But actually, evidence-based practice, it never built a women's refuge. It never built a safe house. No, so it's like these ideas that we've given, it's not the same. We don't need robust science. We do. But if we look at weight, we are not getting robust science within the parameters of evidence-based practice. So it's almost like having the audacity to question these things, even if nobody else is, and then have the conversation. And I think what we need is communities. The way that I think is building knowledge communities where we can show up and we can get it wrong and we can sort it out. And the bottom line is that we know that we share about, you know, respect and accountability. For me, that's what I find really helpful. And it doesn't necessarily have to be on the topic of health or weight, although I tend to manage to bring it back to that.
You know, but going back to how can we engage with, you know, these little voices, I think you have to be our voice. You have to take it to the next step. You know, so yes, they're moving in the right direction. And if you're at a place that's past there, you're going to have to be the one that, like me, just said, yes, but what about? And everyone's going to roll their eyes at you and say, can't you just be happy with baby steps? You know, like All About That Bass was this huge thing. And those of us that were saying, you know, well, it's kind of problematic that we're, you know, shaming women of a certain type of body or making it about how men find us attractive if we've got more curves, or, you know, all these kinds of things. I was like, can't you just be happy that... And one of the things that I've learned over the last few years, you know, because when I came to this, I came from my background's biomedical science. And I've stumbled through this and learned as I've gone along. And I've frequently said the wrong thing, done the wrong thing, and been jumped on by people I would call radical activists, and who our colleague Deb Burgard would tell me off for calling radical because they were just fighting for human rights. And the thing that I've learned is that almost invariably, no matter how obnoxious they are, they're usually right. And, you know, somebody's already said to me today, and I hear it a lot, I've never thought about it like this before. You know, and for most of the people that you come across, just being the voice that makes them think about it, you know, just to raise the issues, that's what will gradually change. Whether or not we can organise sort of more concretely with, you know, like organisations, you mentioned companies, I don't know, because as Lucy said, commodification, where everything becomes commodity, they're selling us our self-respect back. You know, I don't know that you can actually work through that framework in a genuine way. But I guess it all helps. Yes.
Who are the role models that the public eye we could look at that espouse your values? Bearing in mind that we have a lot of thin role models who are supposed to be very, very good and doing all these wonderful things, keeping thin and so on. Can you think of any? I was also thinking perhaps the States is probably a better arena for finding ladies like that. What do you think?
Did you mean role models in terms of, so fat people, or do you mean role models in terms of values? I'm not sure I can answer either, but
what I was thinking was that we are, what you were saying, we're bombarded by this sort of thin look, which if we want to, we can follow it and be a success.
So I think,
be happy. The other side, a lady.
So fat people, I think that's part of the problem. Visibility.
Yes.
So that there is a real lack of visibility and that hence marginalised groups.
Yeah.
And that what happens is
French actually. I mean, she comes to mind.
And then she had weight loss surgery.
Yeah. So Roxane Gay actually turning up she's speaking in London. Anyone know Roxane Gay, an American author who wrote the brilliant memoir Hunger, talking at the South Bank Centre.
She also had weight loss surgery.
Did, yeah. And for me, it doesn't stop her being a role model.
Yeah. That's a very contentious point within size acceptance circles. But I think one place you can look to for inspiration and what's kept me going for the last however many years is what I mentioned, the Fatosphere. So there's an online community of bloggers who write about this stuff. The one who I want to be when I grow up is Reagan Chastain, who blogs as Dances with Fat. So if you just Google that, Dances with Fat, she's a dancer and a choreographer, and she is just very prolific. She writes every day, and she writes things that I'm like, exactly, how did I not see it in those words? And you could live happily ever after in her archive. So I have found so much strength from the Fatosphere, from the people that write in it, from the people that blog in it, from groups around it, because it's just nice once in a while to be in a room full of people, whether it's a digital room or a real room, where you don't have to justify your existence. People that just really get it and support you and just allow you to be yourself. And I found that's what's helped keep me going, because it can be very challenging. And then you have all these real world role models and actresses. Kate Winslet, I think, is very good. She's not fat, but but she's very, very clear on the importance of, the messages that she sends to her daughters and all the rest of it.
And the runner-up in X Factor on Saturday is a very large girl. I mean, I don't know if you saw her. Her name is Scarlett Moffat, but she's rather big. She was a runner-up, so she did very well. So there was really stigma on her weight.
I think one of the things as well is that with the lack of visibility, it's great to have role models, but we want people to have permission to be ordinary as well. Just to see people doing ordinary things, and that would be okay.
Yes, but it's this constant reinforcing of that's the way to be, or that's the way to have. I mean, it's really shocking to fit in.
I was interviewed a while ago on the radio, and it was just after, I think it was Israel had brought in a ban on runway models with a BMI below 18.5. And the guy interviewing me said, so you must think that's a good move. And I said, no, I mean, sure, there are people with eating disorders and they have, varying sizes. But what the problem is not that we're seeing very thin women, it's that we're only seeing very thin women, as this is the way that a body has to be. What we need to see is bodies come in all shapes and sizes. We need to see ourselves represented, not just doing amazing things like, Lucy said, as, Jessamine Stanley came to mind because she was in the paper the other day doing something absolutely impossible with her body. She's a bit of a yoga guru, she's a plus-size yoga guru.
We need to wrap up, so we've just got maybe one or two really quick questions.
But yeah, just the idea that you have to be remarkable. We just need people like us living their lives and being allowed to do it and being acceptable. One more question, and then there's a wrap-up activity I'd just like to do.
It's not so much a question, just a quick observation. You mentioned about microaggressions earlier, and then we're all asking ourselves, how can we join up expecting a societal change when really the change can only come from an individual? So we meet microaggression with micro-compassion and micro-understanding for that person's microaggression.
I love that. Micro-compassion, that's wonderful. And that actually fits quite well into what we wanted to finish up on. So just for the last couple of minutes, This is actually Lucy's idea, but it's me talking for a change. Just jot down or talk to the people around you. What's changed in you today? What will you do differently, either for yourself or in your practice?